coming back to our team, we are a team of surgical oncologists, medical oncologists, hematologists, plastic reconstruction surgeons, and pediatric oncologists at Medicare hospitals at Financial District. And just to look at the raise of hands, if anybody can do, how many use dual tracer technique for SLNB? So only Dr. Satish is there. Okay, dual tracer, nice. So what is the problem? Everybody knows the problem is basically the morbidity associated with the axillary lymph node dissections, the lymphedema, neuropathy, and functional problems. Everybody wants to reduce it as much as possible. So with the advent of neoadjuvant chemotherapy, we started seeing patients with pathological complete response, PCR at tumor and PCR at the node. And when we had analyzed these patients with node positive patients becoming node negative after neoadjuvant chemo, almost 40 to 60% conversions were happening. So there is a window of opportunity where such almost 40-50% of patients can be avoided axillary node dissection. So coming back to our this thing, we will just look partly at the theory, global data, and Indian context, how we can implement SLNB or targeted dissection in post-NACT setting. We know that post-NACT there is fibrosis which leads to aberrant lymphatics, and that's why going into aberrant channel of tumor passage from the primary to the node, and this chemotherapy induced scarring leads to abnormal lymphatic pathways, and that's why there is chance of missing the nodes. So coming back to biology also, what is responding and what is not responding, that is the thing to be identified. And we have seen that luminal tumors are not greatly responding, they are not giving great PCRs, but HER2 positive and triple negative tumors are, though they are aggressive, but responding. So these could be the ideal candidates for such de-escalation treatment. And based on the nodal PCR and the IHC subtype, we have seen that only 10 to 15% will respond, which are luminal. Triple negative, almost 30 to 50% response is seen, and HER2 positive patients, almost 50 to 70% response rates are seen. So that brings back to how we do SLNB in post-NACT setting. We have overall pooled data. This is combined pooled data from different papers, and found that 88 to 91% identification rates are there, and 11 to 15% false negative rates with SLNB alone. Okay, so there is a gray zone. We have a holy grail of 10%. That 10%, it should be less than 10%. FNR should be less than 10%. But the SLNB alone group, in the previous numbers we saw almost 13 to 15% gap is there. So 13 to 15% FNR is there when SLNB alone. So there is a 3 to 5% gap to be covered to reach the holy grail of 10% mark. So two trials, Sentina and Ecozog, I think in ad nauseum they have been discussed a lot with lot of conferences, where the final conclusion is FNR drops to 10% if dual tracer technique is used and at least 3 or more nodes are retrieved. Similarly, in the Ecozog also, more than 3 nodes retrieval was mandatory in that trial. So this strict technical optimization is the thing to be achieved to get the 10% FNR rate. How to reduce the FNR based on pathology? Now the third trial in the same group, SNFNAC trial, they had even stricter pathological criteria, where they did IHCs on the sectioned lymph nodes, and they brought down FNR to 8.4%, where they had considered ITC also as node positive with dual tracers again. So coming back to tracers, so the mandate is you have to have dual tracer technique to call yourself that you are doing optimum SLNB. Without that, we should not label ourselves that we are doing SLNBs. So combine radioisotope and blue dye. This is not an option that lot of places, lot of centers, we are trying to dilute by going into only single dye technique, but you can't match those results ever. The benchmark is dual dye. Single dye is 19% FNR, dual dye is 11%. Second part is surgical technique to retrieve the node. We have to be meticulous in the early learning curve. We might not be able to retrieve nodes, but we have to be smart enough. We have to train ourselves and make sure that 3 nodes are retrieved. It brings down the FNR from 20 to 25 to 5 to 11%. Now, what is the theory behind targeted axillary dissection? So, there is almost 10 to 20% discordance of lymph node, the metastatic lymph node getting selected for the biopsy, or it comes in the specimen. So, there are chances that the clipped node might still harbor the disease, but the SLNB misses it. The sentinel lymph node is not picked up. That leads to understaging. So, how do you define the targeted axillary lymph node dissection is you do the sentinel node mapping, you do the marked node retrieval, only then you call yourself that you have done targeted axillary lymph node dissection. So, the rationale is clipping the pre-NACT node which was positive, which might not be the sentinel node always. By doing TAD, we are ensuring that the clipped node which was positive is also picked up. The sentinel node as per the lymphatic pathways is also picked up. So, there was an MD Anderson's paper about the proof of concept of how to implement TAD. SLNB alone showed 10% FNR, clipped node showed 4.2%, and when both were combined together there was 1.4%. So, removing both the nodes improved the FNR drastically. There are multiple papers which have given pooled FNRs at 5.2%, 4.7% and 3.6%, and the bottom line is dual tracer technique, at least 3 nodes retrieval. So, this is how you have to implement. You have to take 2 dyes, pre-NACT marking of the node, targeted axillary dissection. This is getting oft repeated, it will be repeated again after some time, but these are the things to be remembered. FNR comes down to almost 5%. Identification rate is reaching up to 99% with this technique, and the proof of concept paper showed almost 1.4% FNR. So, we are de-escalating, but are we safe in doing that is the next question always. So, axillary recurrences in this group of patients when followed up for a period of 3 years was only 1.8%, and this paper is a prospective registry data from the German. And long term, so in breast cancers nobody wants 5-year and 10-year. Deepak will always tell give me 15-year data, 20-year data for survivals in breast. But right now we have only this much mature data. So DFS is 85 to 90% after 5 years, and overall survival 90 to 94%. So conclusion is 5-year survivals, there is not much difference. So axillary recurrences 1.8%, almost 90% DFS, 95% overall survival. So this 5-year data, we can conclude that de-escalation to targeted axillary dissection, the way we described, we can precisely remove the affected lymph node and stage the axilla post-NACT. How do we implement? Partly this was taken care by Jwala ma'am, so I can borrow from there also. Clip and wire, she told it's easily implementable, it is cheap. Radioactive seeds, she had described, magnetic seeds, mag seeds. And fourth one is carbon tattoo, where carbon suspension is injected into the node pre-NACT, and this carbon is retained in the node post-NACT. This becomes a marker for us with naked eye, apart from dual dye, which is a must. So there is a heterogeneity of what markers you will use or what technique you will use. When there is heterogeneous data, you can't conclude directly that yes, this is the best. There is no one single technique which is suitable. Only thing is we have to pick up what suits us in our conditions. So 3 important phases where everybody has to be at their best is pre-NACT radiology. The radiologist has to be expert. At one paper they have written intermediate to senior level radiologist, breast sonologist, whose job is to just do breast radiology. Such kind of precision required at every step. Second is intraoperatively, which I told surgeon's expertise. And third is pathology. Pathologist has to be super smart to identify, because we are leaving a node which is not pathologically positive, which is basically pathologically negative, we are leaving it behind. Suppose if there is a disease, we are risking. Coming to Indian context and adaptation, till last year where I was in Vizag Homi Baba, I was actually interested in preparing a paper, a prospective trial. That's why I was happy when Dr. Satish Pawar told you have to talk on this. I had enough papers read and collected. So, Indian database, Yadav et al. From Jabalpur, they have made a paper where they found that in Indian studies, there is 85% identification rate, 17% false negative rates. These are high than standards. Why? Because we have diluted the dual dye technique multiple places. We are going to single dye because it is easily available, it is cheap, that's why. But that cannot be a reason to de-escalate. We must, taking forward that SLNB alone is insufficient in our settings, we must adapt targeted axillary dissection. This was the famous tattoo trial where they had injected sterile carbon suspension. So first is pre-NACT, identify the node, get a biopsy, prove it is positive and mark that node. And this black node will be appearing later in your axillary dissection post chemotherapy. The tattoo trial had given 93% targeted node dissection, 6.2% false negative rates. It appears cost effective, but nobody has tried. I called up, when sir said, I called up my faculty at Tata Memorial, Dr. Somshekhar, I called up Dr. Ashutosh at AIMS to identify what they are doing. It is just, they have done some 5-6 patients, they have tested and tried the clip method. Everybody is doing clipping. And now they are trying to maintain a prospective database of such patients and how we are faring. So the ideal candidates are, how do we select them? If we want to attempt a program at your place which are high volume, and when Deepak in the morning he told we can collaborate together in Hyderabad. So we have to pick up candidates where there is heterogeneity again, N1, N2, N3. To start with, we can start with N1 positive. Radiologist can identify, and HER2 positive triple negative cancers might be the best candidates to start, and we should of course do dual tracer and more than or equal to 3 lymph nodes. These are the places where we should start. So this is just a single slide where I wanted to differentiate between the FNR and T node retrieval, but it's okay. Thank you. So just to remind everybody that SLNB, doing SLNB and making it, finding it negative is not enough. The targeted node might be somewhere else. The node positive node might be somewhere else, which might be missed. We have references ready and I can share all the papers who are interested. Thank you very much.